When we do the TMS EMG with the electromyography, you not even need the cup with the electrodes. You only basically have a coil that is put on top of the scalp. It's non-invasive, so nothing, like it's just external here. And then you may hear the click from the stimulation. That's it.
Who knows about TMS, or transcranial magnetic stimulation? Well, it's a form of neuromodulation, it's not painful, that has been used rather well in helping some people with depression. But now research is being performed to see how it could be used to help people with a refractory epilepsy. It could potentially be used as a biomarker to treat epilepsies more effectively, but it could also even end up being a treatment in itself. Today we hear from the fabulous adult and child neurologist, Simona Balestrini. If you haven't done so already, please press the thumbs up in this episode, comment below and subscribe to our channel so that we can get way more people around the world, clinicians, patients and the general public, learning facts about the epilepsies.
I'm an adult neurologist by training. I did train in Italy and then I moved to the UK to do a fellowship, to do my PhD, and I worked there as an adult neurologist and I'm still working there at UCL Department of Epilepsy. And then 5 years ago almost, I also took on a position as a pediatric neurologist in Italy. So now I'm working between both sides. And so I work as both pediatric neurologist and adult neurologist with special interest in epilepsy and even more in genetic forms of epilepsies.
Goodness. And so how much of your time is spent, like say percentage-wise, on clinical work versus research?
On average, let's say I do 60% clinical work, both in Italy and the UK, and then 40% research work.
And actually, you know what, I was just thinking, we say that, but it probably amounts to more like 150% in total,
exactly.
Doesn't it?
Absolutely. And, in the end, is also all mixed up because, sometimes, of course, you try to put your research in clinic to try to give additional information and the other way around as well.
I really am not very familiar with, and I know heaps of our listeners are not familiar with TMS. What is that? What does it stand for? And what is this thing, this service?
TMS stands for Transcranial Magnetic Stimulation, and is a methodology which is actually not so new because it's been used now for decades. And the way it works, it is that it gives a magnetic stimulation, a very small magnetic field, similar to the one that is used in a brain MRI scan, but the magnetic field is much smaller. And this small magnetic field is able to activate some neurons in the brain, so to stimulate the brain, so there is some electrical activity. And what it is very useful for is to record how the brain responds to the stimulation. So it gives us an additional layer of information compared, for example, to MRI scan, where you get structural information from the brain, or spontaneous EEG, when we have EEG during resting, we have like information on brain activity. But in addition, with TMS, we try to understand how the brain responds to a perturbation. So it's a sort of active probe for the brain.
So it's like you can zap a little bit, a targeted part of the brain, to see how it will behave upon that zap.
Correct. That's very good. Yes.
How are you researching the epilepsies, or a particular type of epilepsy, using this method?
So we're starting applying TMS in people with epilepsy by using TMS coupled with the EMG, because the TMS, it just gives the stimulation, but then we need a way to record the output from the stimulation. And the most widely used way is to combine TMS with EMG, electromyography. So basically we put an electrode on the hand muscle, and so we stimulate on the motor cortex, and then we'll basically obtain some twitches from the hand. And of course we measure then the sort of response, because then the stimulus goes from the brain to the spinal cord to the muscle, and that's the output. But that's a bit limited because you only probe the motor cortex. When we combine TMS with EEG, then we can get information from the whole cortex. So that's the added value.
Can you describe what it looks like?
When we do the TMS EMG with the electromyography, you not even need the cup with the electrodes. You only basically have a coil that is put on top of the scalp. Is non-invasive, so nothing like, it's just external here. And then you may hear the click from the stimulation. That's it.
Like that?
It's like sorry, I may not be able to reproduce it well, but that's the sort. It's a click. Sometimes you can have a little of feeling like a prickle, something like, it depends also on the intensity of the stimulation. And then if it's with EMG, you will have a twitches from the hand, like this. Okay, so that's the EMG. With EEG, you have no twitches. It depends on where you stimulate. But then, of course, you have at the same time the classic EEG recording with the EEG cup.
And so it doesn't hurt or anything, and there's no scraping of the scalp.
It's the same procedure required to put an EEG cap on. You do some scratching just to put the gel to do the sort of impede, but that's it. There is no other sort of invasive procedure required.
And so I'm going to refer to one of your very interesting papers about this now. TMS, transcranial magnetic stimulation as a tool to understand genetic conditions associated with epilepsy. How on earth does it help you understand the genetic ones more?
That's a very important question. Well, one of the first questions we had was, okay, how do we go from a person who has a genetic mutation to understand how that mutation lead to a epilepsy with additional issues like sometimes learning difficulty, as you know very well, psychiatric problems and so on. So of course we always do our sort of more routine procedures such as MRI to see if there are structural abnormalities, normal EEG to see how active, how severe is the epilepsy. We do psychological tests. But then we also wanted to add an additional layer of information through TMS because we know that when there is epilepsy, there is an imbalance between activation, excitability process, so when the neurons are more active, and on the other hand, inhibition. This is a normal process that happens all the time in the brain, but sometimes these excitation and inhibition processes get some imbalance, and that's in many also model seems to lead to epilepsy. So we know that, especially with the TMS EMG that is much more used, some specific protocol we do correlate with some level of excitation and inhibition. And so we applied, for example, TMS in Dravet syndrome, where we know that one of the problems is that the sodium channel doesn't work properly, and this mainly affects the inhibitory neurons, so some neurons that are most involved in inhibition. And in fact, we saw a nice correlation between people with this syndrome and their output in the TMS EMG. And the same has been done for other single gene epilepsy, so where there were mutation in other specific gene where we know what gets wrong. But of course now our question is to extend this to other genetic causes, because genetic causes can be many different ones. And also so far this evidence is mainly from EMG, so just from the motor cortex, but we think it makes more sense also to extend the study to the whole brain through the EEG. So that's why we are now trying to explore also what TMS EEG can add to this understanding.
I'm just imagining like you getting these readings and the professions required to actually analyze this data together from different sources. It must be a pretty big deal, right? Collating all of this and then looking at it as one.
It's not easy. Even just acquiring the data is not easy because, you know, it's a long process. It's not immediate. It's not like we do a scan. It's a complex procedure. It's time consuming. Sometimes people get tired. So yeah, it's not straightforward, but I mean, we at the moment is still on a research basis to try to answer this question, but we believe it's potentially interesting.
How long does each reading usually take? I mean, I'm sure it's different for each case, but like, is there an average amount of time you spend with each patient having this? For
the actual procedure, so when we give the stimulation, I think an average session lasts probably 2-3 hours per patient.
Oh, it's a good while.
So it's long, yeah. And then, of course, we then do the reading separately. And we may not also immediately feedback information on the patient because we then analyze the data all together. It's not like an immediate feedback that we can give to the patient.
No, of course. So we could be looking at weeks, and that's having access to the right people who know how to analyse this. You think about zapping one's brain, and that idea scares quite a lot of people who have an epilepsy because they're like, mate, I already feel zapped enough with my seizures, if they have them still. So I know that you've done a paper just to prove that it is safe for people with an epilepsy. Can you tell us about that, please?
Well, we also wanted to establish safety first because, of course, we give a stimulation to the brain, so we could not exclude 100% that we are not eliciting some additional activity. But then what we did, because there are different ways to deliver the stimulation, so what we use for research purposes is single pulse or pair pulse. So it means we just give one off stimulus, and of course we still repeat them, but with a large interval in between, or two close stimuli. That's it. There is another way, which is repetitive, which I may mention if we have time, which is more used for treatment, although not in epilepsy yet. We are also looking into that, and hopefully we will have some more answer. But this is just to say that when we checked whether the single pulse or pair pulse protocols were safe, we of course apply this different type of stimuli in people with epilepsy, and we compared first of all the EEG pre and post, but also their seizure frequency the 3 months before and the 3 months after, and we confirmed that there was no significant change in their EEG activity burden of abnormalities and also on their actual seizure frequency. We are now actually extending this study. We have many more people that now we have tested with TMS, and we can confirm that this technique with this sort of different type of stimuli is safe and does not worsen seizure control, which of course is the main concern.
And also from what I read, you even include people with sort of the rarer epilepsies who often have more frequent seizures anyway, and their seizures were not worsened or made more frequent. So that's really quite reassuring, I think.
Indeed. What we are exploring is, of course, what additional information TMS can give us in terms of underlying mechanism. So genetic basis, or sometimes there are other causes. So we want to see whether it can give us additional understanding of the processes. Mm-hmm. But also we would like to see whether it can also help us to have a sort of measurement of treatment response. So for example, if I do TMS in a person with a specific type of epilepsy, let's say Dravet syndrome, and I see an abnormal response, then I start them on a treatment, they improve, and perhaps also their TMS response improves. So then I would like to go back and see how their initial response looks like, and see whether somehow I see in that response a marker of that can predict treatment response. And so then I will go back to other people and I will know, look, it's quite likely that you respond to it, because as you know, at the moment, we don't have predictors of response. We say, okay, we start this medication, we hope it works, but we don't know 100%. And maybe we can add some biomarker from the TMS perspective. This is another direction we are taking. But also what we are interested in is to see whether TMS can also be a treatment. You know, neuromodulation as a non-pharmacological treatment has been more and more explored, at least in epilepsy, with some positive results and some validated one, like vagus nerve stimulation, which is also considered neuromodulation. Also in rarer cases, deep brain stimulation. But these are all invasive in a way. At TMS, in epilepsy, there have been very few studies, very, very few, with contrasting evidence. Some showed benefit, some didn't show benefit. While on other fields, such as psychiatric condition, for example, in depression, actually it is considered an effective treatment, and it is used on a routine basis to treat depression, to treat obsessive compulsive disorder. So on this basis, we are now designing a clinical trial to see whether perhaps we can use it also as a treatment. But at the moment, there is no evidence, so we don't really know.
So studies are required first, and that's what you're in the middle of, right?
We are hoping to be able to do that.
This is exciting stuff. And as you're mentioning the psychiatric side of what affects a person's quality of life, as well as the seizure frequency or severity. So bringing those two together and helping improve the person's life for both those things would just be brilliant, I think.
Yes, exactly. Yeah, it would be a nice complementary effect.
Thank you to Simona for telling us all about TMS and getting us excited about the potential it may bring to improving the lives of people with an epilepsy in the future. Check out more about Simona at the website torierobinson.com, where you can access this podcast, the video and the transcription of the entire episode all in one place. And if you haven't done so already, please do press the thumbs up for this episode, comment below and subscribe to our channel so that we can get way more people around the world, clinicians, patients and the general public, learning facts about the epilepsies. See you next week.